Since this presentation was recorded in June 2017, the American College of Cardiology and American Heart Association have provided a new set of high blood pressure guidelines, lowering the definition to account for complications that can occur at lower numbers and to allow for earlier intervention. The new definition, 130/80 rather than 140/90, will result in nearly half the U.S. adult population, 46%, having high blood pressure, with the greatest impact expected among younger people. The prevalence of high blood pressure is expected to triple among men under age 45 and double among women under 45. However, only a small increase is expected in the number of adults requiring antihypertensive medication. High blood pressure should be treated earlier with lifestyle changes and, in some patients, with medication. As explained by Dr. Paul Welton, lead author of the guidelines, if you already have a doubling of risk, you need to know about it. It doesn't mean you need medication, but it's a yellow light that you need to be lowering your blood pressure, mainly with non-drug approaches. That concludes this update. Let's continue on to our main presentation, hypertension, relieving the pressure.
Welcome to CareOregon's ongoing series of education sessions dealing with chronic disease states. Today, pretty obviously, our focus is on hypertension. Here's kind of a rough outline of the agenda that we're going to be following here today. Times are kind of approximate, but that's generally the lay of the land that we'll be doing, talking about guidelines, medication management, and nutrition and lifestyle. With hypertension, I'm sure, as you guys know, we're talking about a huge problem. World Health Organization estimates that 1 in 3 adults worldwide has high blood pressure, and in some parts of the world it can be as high as half of adults that have it. High blood pressure is one of the most important contributors to premature death from cardiovascular disease worldwide. It contributes to nearly 9.4 million deaths due to heart disease and stroke every year. One statistic I've seen says 1,000 people a day in the United States pass away due to hypertension-related cause. Together, heart disease and stroke, #1 cause of death worldwide as a result. The good news is high blood pressure is preventable and it is treatable. You see how big of an impact it has on our population in terms of Medicare and Medicaid, so it's something very familiar to folks in this audience. So what we want to try to do today is see if we can get some good, tangible, practical perspective on how we can address it and cope it and make things better. People always have questions about what's covered. And so you're going to find in your packets that this is also a handout. So don't worry about frantically trying to copy down these phone numbers or anything like that, or these claim numbers in this particular case, because blood pressure cuffs are covered. They are something that's part of the medical benefit with no prior authorization required. You're also going to see towards the bottom on here, there's some very good advice about blood pressure cuffs, and that best practice recommendation here is for arm cuffs, not wrist or finger cuffs. And there's a very, very nice link that one of our presenters has provided here where you can go and you can see if the particular cuff you're looking at is something that's been validated or not. Hi.
Hey, is there a specific ICD-10 code that needs to be added to that to be medicated?
The only codes I know are the 2 that we have right there, but we can certainly follow up for you on that. We can just check with us at our pharmacy benefit specialists. We can look that up, but we want to make sure that there's just no ambiguity about getting these out for folks. So very, very straightforward. So enough of my talking. What we want to do is get into our content and our presenters right away and start talking about our guidelines. To begin with today, we're going to welcome to the stage Dr. Jose Rueda, who is an associate professor of medicine at Oregon Health Science University. He joined the Division of Nephrology and Hypertension in 2014, finished internal medicine and nephrology training at Washington University in St. Louis, Missouri. For the last 4 years, he's been director of the American Society of Hypertension Certified Comprehensive Hypertension Clinic at OHSU. Please join me in welcoming Dr. Jose Rueda.
Thank you. So I've been doing this for the last 4 years, but I'm a full-time clinician, full-time nephrologist. And for the last maybe 4 years, we started doing this hypertension clinic at OHSU. and now has been morphed into patients that take 8, 9 medications, and they have multiple allergies. And that's what we really deal on a weekly basis. Sometimes we find a pheochromocytoma. Sometimes we find an aldosterone-producing tumor, but I don't see the people that take one medication anymore. And sometimes it's nice to see somebody that is well controlled. That said, monotherapy is a thing of the past. Most of the people that they're seeing in clinics at OHSU take 2 medications to control the blood pressure. And if you look at every single clinical trial that has happened in the last 24 years, 60% of them have to take 2 meds, and I'll show you some of that data. So sadly, another year without any disclosures. So what we're gonna do today, we're gonna go through these 3 things. That's a misspell, there is JNC8 guidelines. We'll review one of the most recent clinical trials, the SPRINT trial, that has changed a little bit what we do in our clinic. And we'll go through these, the most common causes of secondary hypertension. If you see a patient in the clinic with high blood pressure, 95% of those patients are gonna have essential hypertension. Only about 5% you're gonna find a secondary cause, okay? And those sometimes we see in our clinic, and we have to order all these testing, aldosterone and plasma renal activity. What we've seen is that doctors and nurse practitioners and nurses, sometimes they order these tests, they're about $300, and they're not ordered the right way. So the average money that they spend before those patients get to us is about $1,000 in aldosterone and renin and potassium levels. And they're all drawn in the wrong way and so forth. And I explained to you what the guidelines, the Endocrine Society has guidelines now published about a year or so ago that really explain to all the providers what the JNCA didn't do, how to do this testing and how to save money. If you test for aldosterone and renin in every single patient that you have, you're gonna bankrupt every healthcare system. So we have specific guidelines, when to do it, how to do it, and so forth. So that's very important. I always say that people spend more money on vitamin D levels. It's like $100 that they charge you for that. And I haven't seen the first patient that tells me, if it wasn't for vitamin D, I wouldn't be alive today. But if you screen these people with aldosterone and renin, the ones that need to be screened, you can actually identify something that you can cure. So it is a huge problem. I don't have to discuss this any further, but we spend a lot of money in direct cost and indirect annual cost, people that miss work and so forth. $73 billion is the most common cardiovascular risk factor after smoking. And the lifetime risk at age 55 for developing hypertension is almost 90%. So just a few people escape. So this is a huge problem. Are we doing better? Yes, indeed, we're doing better. We're doing better than a lot of European countries that have low rates of control, like 30 or 40%, even in England. Here, this number is improving. Up to 50% of our patients that we see around the United States, based on these surveys, are controlling. By that I mean the blood pressure is below 140 over 90. So I'll look into this website a few days ago and try to figure out, has it changed the percentage of patients with high blood pressure in the last 20, 25 years since I finished fellowship in med school? And the answer is no. We still have about 30% of the adults with blood pressure that is as diagnosis. But like I said, in 2014, the control rate has gone up to 54%, which is great. So what is hypertension? The JNC8, which by the way is not going to happen anymore, the Joint National Committee is not in charge of setting up guidelines anymore. It appears that the American Heart Association, in combo with the American Society of Hypertension, is going to be providing these guidelines from now on to all doctors, okay? So the last version of that was the JNC8 a few years ago. But they didn't change the definition. The definition is the same thing. 140 over 90 or above, you have hypertension. You have this pre-hypertension area there, and Europeans don't have that. And sometimes they claim that Americans created 40 more million neurotics because we tell them that they have pre-hypertension, but there is nothing that we can do for you. The risk of, besides changing the way you live your life, the risk of developing hypertension at 2 years when you have pre-hypertension, flip a coin, is about 50%. So those people have to be counseled. Hey, exercise more, change your diet and so forth, because there is a great risk that in 2 years when I see you back, your blood pressure is going to be 145 over 95. Stage 2 remains the same, anything about 160 over 100. And I want to point out, look at the identifiable causes of hypertension, and that was one of the themes of that JCEM, that they wanted the providers, hey, pay attention to these 5% of patients that they may have a cause that you can identify, and some of them can be cured. For example, pheochromocytomas is the most sought out tumor, the least found. Only about 800 of those are diagnosed in the United States per year. We have seen 6 in the last 10 months. Why is that? We're getting more CT scans done in the abdomen. And it appears that 50% of these pheochromocytomas don't have high blood pressure. So you see the pheo on X-ray, and the X-ray trumps the biochemical analysis, meaning that if he looks like a pheo, if he looks like a thief, he goes to jail. That's the way we look at CTs. If he looks big and the Hansel units are elevated, that's a pheochromocytoma, even if they don't have blood pressure, and they go to the OR and get that tumor out. The good thing is 4 centimeters is the average size of those pheochromocytomas in the abdomen. So if you have symptoms, you usually have a big factory that is about 4 centimeters in width. The other one is primary aldosteronism. Is the most common cause of secondary hypertension nowadays. And that's the reason I want to stress this issue, how to do aldosterone and plasma reactivity to screen this patient. If you have resistant hypertension, if you take 3 meds, including a diuretic, 20% of those people may have a positive screening test for primary aldo. All right? So those are the ones that most likely you should screen for that. Why? Because you may find something in the adrenals that is producing the aldosterone, and you can blockade that receptor in the kidney, or you find a mass that is benign that you can remove and cure some of these patients. The other one is sleep apnea. That's a weird one because the prevalence of sleep apnea in patients with resistant hypertension is very high. It's about 80%. So when you screen them in our clinics, we don't even ask them if they are snoring anymore. Just go straight to the sleep apnea testing because it's going to be positive. These are patients with resistant hypertension. But when they start wearing their CPAPs, the response on the blood pressure is not the greatest. Guess what is the most common drop in the systolic number in people that wear CPAP machines after 6 months of being diagnosed with sleep apnea? 2.7. So don't expect that these people are going to cure from the high blood pressure when they start wearing the CPAP. But obviously there are other benefits that you get by treating that. Drug-induced, obviously we have epogens and tacrolimus and cyclosporins. All those medications will increase your blood pressure. Renal vascular disease, maybe less than 1% of the people that we see with resistant hypertension have a lesion 80% or greater in the renal arteries that is causing this problem. Coarctation of the aorta, I've seen 2 cases in the last 10 years. This thyroid and parathyroid disease is also kind of funny. If you have hyperthyroidism and you get treated for that, you still need blood pressure meds. Don't expect that the hypertension is going to go away when they treat your hypo or your hyperthyroidism. That's our clinical experience. But it's good to know that, hey, look at those identifiable causes and do some screening testing on these people. The easiest one is to get a creatinine. You have CKD, that most likely is contributing to your blood pressure. So the classification hasn't changed. And these are 61 prospective studies involving more than 1 million people. And what I'm trying to tell you is your risk of cardiovascular mortality doubles up every time your systolic goes up 20 points. So if you start at 115 over 75, where I want to be, you go up 20 points in your systolic to 135, your risk of dying from cardiovascular disease has doubled already. This doesn't mean if I get you down to 115, I'm going to improve your risk. But I'm going to talk about the SPRINT trial that has some interesting data regarding this issue. So systolic blood pressure matters and is important to treat. I'm going to start with some of the randomized clinical trials that they used to set up the new guidelines a few years ago, the JNC8. So they took the best data that we have out there, the best scientific data, randomized clinical trial that had more than 100 patients. They didn't take really any observational or epidemiological data. So the best that we can use to set up guidelines. And here's to show you for the biggest randomized clinical trial looking at adults and goals of less than 150 over 90. Four different trials. The one that I like the most is the HYVIT, because had patients that were 80 years or older, and they used an ACE inhibitor and a diuretic. And they found out that even when you treat these patients at 80 years old, that 10 years ago, 15 years ago were kind of oblivious to the blood pressure control, you make a big difference. You keep them out of nursing homes, and the risk of death goes down by just using very simple medications. And so what is the risk reduction? Look at the HYVIT. This is 2008. Looking at, this is a European trial, indapamide and perindopril. We don't use indapamide too often here, but it's a great diuretic. The half-life is between the half-life of hydrochlorothiazide and chlorthalidone about maybe 16 hours, and it works very well. And the reduction in a stroke, when you get the blood pressure down to 150, was 30% down, and the risk of death was down to 21%. So these trials show that, hey, in the adults above 60 years of age, getting the blood pressure to 150 or 90 or below that makes a difference, correct? What about data? What if we go down even further below 140? Does it make any difference? And the answer is no. Based on those 6 randomized clinical trials and more, because they have plenty of data to review, the investigators at JNCA came out with that guideline. Hey, if you're above 60, the data supports that less than 150 over 90 is good enough. If you go down to 140, like in those 2 large trials, more than 4,000 patients in each one, there is no difference in primary outcomes or secondary outcomes, correct? So based on your guidelines now, if you're an adult above 60, less than 150 over 90 is a great guideline for these people. So what about diabetics? And this is the best trial that taught us, hey, maybe we should not be that aggressive in blood pressure control. So this is the trial that really you have to remember in diabetics, and the SPRINT trial maybe is the one that you have to remember in non-diabetics, correct? Because it taught us a lesson. They're almost exactly the same in terms of the goals and the goal in the blood pressure and so forth. This is about 4,700 diabetics type 2. And they had 2 goals, 140 or 120, simple, correct? And those were the primary outcomes, non-fatal MI or a stroke or a cardiovascular mortality. The split up in the 2 curves was great. They really went down to, I think at 1 year, the blood pressure was 119 on the intensive and about 133 or 131 on the non-intensive arm. You don't have to even look at the data here. The event rate was very small, but there was no difference in outcomes. So it doesn't matter if you get him down to 120 or 140 in diabetics, 140 is good enough. Even the American Diabetes Association guidelines up to 2015, 140 over 90 is acceptable. And I'll show you some of that stuff. So this ACCORD trial argues against intensive blood pressure control in high-risk diabetic patients. So 140 over 90 is good enough. Just remember the ACCORD. What I said a few minutes ago, it takes more than 2 to get you there. Okay? And how fast do you need to get to goal? I'll show you the SPRINT trial. They saw them every single month for 3 months in a row and then every 3 months. And they got to those goals pretty fast. And there is some data that shows you that if you don't get to goal within 6 months, the outcomes maybe are not the greatest. So you gotta work on this. You just can't say, here, take some amlodipine and come back in 3 months. You gotta see these patients at least 4 weeks later or call them in 2 weeks. How is the blood pressure doing and so forth. Multiple guidelines, but I'm going to show you they're very similar, all of them. That's the Joint National Committee, the American Heart Association, the American Society of Hypertension, the Kidney Dialysis and Improving Global Outcome, the American Diabetes Association, and like I said, things kind of changed a little bit with the SPRINT trial, and we'll go through that. These are the JNC 8 guidelines. So they had 3 questions. They started with like 23, but I guess they didn't have enough money. So the first question, what is the threshold for treatment of hypertension? The second one is, where do I go? What's the reduction goal? And the 3, what do we do with CKD and diabetes? So they left a lot of people out, like coronary disease and stroke and so forth. But good enough. My point is, they look at the best data that we had. Randomized clinical trials, excellent. And they gave you these recommendations in terms of the strength. A, strong, B, moderate, C, weak, D, against, and E was expert opinion. And I want to show you how many A's do you see there? Only 2, correct? So A was the strong recommendation to all of us, only in 2 different settings. One was the one that I just mentioned to you, the randomized clinical trials that I show you regarding what is a good blood pressure when you're above 60. 150/90, and that's the best data that they had available at that point to tell you this is a good goal. The other strong recommendation was the diastolic blood pressure in the younger patients, below 90. Oddly enough, we had plenty of data to support that recommendation, but we don't have enough to support the 140 or below. E is an expert opinion, okay? So if you're below 60, 140/90 or below 140/90 is your goal in terms of blood pressure control. And in terms of diabetes or CKD, both of them were expert opinions, and it's the same cutoff, anything below 140/90. So the ADA, for example, a few years ago had these 140/80 of diastolic as a goal. Finally, in 2015, they changed that. It was really based on one clinical trial that actually was negative, but the secondary outcome showed that maybe if you go down on the proteinuria on these patients with diabetes, you may have better outcomes, but not anymore, 140/90. But they give you you can try less, 130/80 in some patients, maybe the younger, and if there is not too much burden. But right now, this is what we have, and this is what we follow, okay? And in terms of how to do it, they don't tell you use diuretics first line. They tell you that you have 4 options. Diuretics, ACE inhibitors, ARBs, and calcium channel blockers, all right? And they don't tell you, you gotta start one first and then go up to the maximum dose of that one and then you add the next one. No, they can tell you can do that, or you can start one and then 2 or 3 weeks later you can add another one and maximize those to at 1 more month or 2 months. So they give you a lot of room for you to try on these patients. Also, in terms of hypertensive with CKD or diabetes, they tell you it's okay to start ACE inhibitors and ARBs, but the recommendation is not that strong. If anything, it's weak. So you don't have to use ACE inhibitors in every single diabetic that you have that has no proteinuria, correct? You don't have to. Just control the blood pressure. If you don't rely on the patient to come back and get a creatinine or a potassium and this and that, put them on amlodipine. And then add the ACE inhibitor later on, or add a calcium, an ARB later on, or a thiazide diuretic. So in a way, we're more less strict on the use of ACE inhibitors in diabetic patients. I'm a nephrologist. Obviously, my salary depends on how many ACE inhibitors I prescribe, and I usually tend to use them often in people with diabetes, even when they don't have microalbuminuria. But like I said, the data is there. It's not as strong, it's weak. So as long as you control the blood pressure you can start somebody on a thiazide diuretic if they have 150/100 and they have a creatinine of 1.5. There's nothing wrong with that, as long as you get to the goal. What about people that have proteinuria? Who benefits from that? And the data show you that really the ones that benefit the most are the ones that have more than 3 grams of protein in the urine, based on 2 trials that are all. So if you have less than 3 grams, boy, that patient should be on an ACE inhibitor or an ARB to lower that protein. Otherwise, there's not a lot of data also to tell you that if you have 1 gram due to CKD, you should start, most likely you're going to need 2 medications to control the blood pressure, and we favor that you include an ACE inhibitor and ARB in the treatment of those patients. What about the American Heart Association guidelines? If you think about it, it's kind of the same. Look, the strongest recommendation on somebody with coronary artery disease is 1A, that tells you should be performed, you should do this, and the goal is less than 140/90. If the cardiologists tell you, well, I want to get down to 130/80, okay, fine, try. But the data suggests that it's not the strong recommendation. Might be considered usefulness is unknown. Right? So we get those consults all the time. This patient is post-MI, how low the blood pressure should be. And based on that, you can try 130/80 if you don't have any symptomatology. But the strongest of the data suggests that 140/90 is fine. So the diabetes, and this is to show you that as of 2015, 140/90 is cool. You can definitely try to be more aggressive in some of these patients, but they don't tell you exactly which patients you want to try. They tell you might be appropriate for certain individuals, so as younger patients and so forth. All right, so we had some unanswered questions. So what do we do? What about the people that have no diabetes? The ACCORD trial show us, hey, it doesn't make any difference between 140/20 in diabetics. What about the people that have no diabetes? So let's do this. But let's get rid of people with strokes. We don't want anybody in a nursing home that cannot open their bottles. Let's do this, but let's do it in people that have very high cardiovascular risk. And the goals were exactly the same like in the ACCORD trial, below 20 and below 140. And that was the inclusion criteria, and I'm going to skip to it because it's similar to the other ones, but they have some people that had chronic kidney disease, and about 30% of them were older, greater than 75 years of age. And let's jump into the outcomes. The primary hypothesis was, hey, if we lower the blood pressure on these people, I think the events rates are going to be lower. And the primary outcome was the composite of those 4. And I'm going to jump into the graphics. This is to show you that Suzanne Wadnick and Dr. Jesse Wise were some of the investigators in our group at the VA hospital. And they could tell you that, hey, these guys needed to be seen often, almost every month, and really crank it up on their medications to get to the goal in the blood pressure. So they saw them monthly for 3 months and then every 3 months. The amount of meds and the type of meds that they use are well known to all of us. The only one that we don't prescribe that much is this azilsartan, which is an ARB that has a half-life of about maybe 11 or 12 hours, definitely longer than captopril. But the rest of them are well known to all of us, okay? So no fancy meds, no really expensive meds. They screened a lot of people, 14,000 patients, and they ended up with 4,600 almost in each arm. And like I said, about 28% of these people were greater than 75 years of age. The mean age in this trial was definitely higher than in the ACCORD. The blood pressure baselines were not bad at all, 139/78. So the serum creatinine was normal. They used this automatic $600 machine to digital, the ones that you can get at Walgreens. I don't know if the same number is sold there, but it's still $500. You don't need to buy a $500 machine to do this, but that's what they did. They didn't use the aneroid to check those blood pressures. So in August 20th, 2015, the investigators stopped the trial. The median follow-up was about 3.2 years. And this is like the same ACCORD slide that I showed you. I mean, they split out the blood pressures very nicely. At 1 year, the mean systolic on the standard group was 136, and on the other one was down to 121.4. So they did a pretty good job. And you can see at the end how many meds they needed. On the intensive group was 3, and in the other one was 1.9. 。 this is one of the graphics that every time I see it and I need to explain to the patient what the results were, patients don't understand this concept of number needed to treat. But here, what he showed is that there is a 25% decrease in the risk of dying if you were to have blood pressure that was almost down to the 120s. So that's an outstanding number. And this is all-cause mortality, 27% as well. So powerful numbers. But what is the difference between the two groups? And if you look at the difference between the events between the two groups is 0.5% only. Okay, so it's a very small difference in events per year. In the intensive group, 5 out of 100 had the episodes and the mortality and so forth. In the other group was 7 out of 100. Okay, so it's very minuscule, but in the big numbers, the reduction is 27%. And it was really in the primary outcome that you see the difference. As you can see, this p-value definitely is significant, as well as cardiovascular death. But if you look, the stroke and the MI really didn't show, correct? So sometimes people ask me, so my risk of stroke is going to go down if I get down to 120? And I say, well, the primary outcome really made a difference, and the risk of dying is going to be lower. But the stroke, I can't tell you really, because if you look at the numbers, there wasn't a difference. What about if you have normal kidney function and they put you on all these meds, at least 3, what happens to your GFR? Is it going to get worse? And in those guys, there was a 30% reduction in GFR in the people that had intensive therapy. And why is that? Well, we use more chlorthalidone, we use more ARBs, we use more ACE inhibitors to get to that goal. So that's expected, correct? What about, am I passing out more often if I take all these meds? What is the rate of electrolyte disturbances? In all the SAE reports, it was similar in both groups. Some of them were more hypertensive and some of them passed out, but the difference wasn't strikingly different. What about hyponatremia? Yes, hyponatremia was a big difference between the two groups. Why? Well, we use chlorthalidone. Chlorthalidone has a half-life of 40 hours. Can induce hyponatremia and can cause hypokalemia. It's a very potent diuretic. It's almost 3 times more potent than hydrochlorothiazide. And the half-life is 40 hours. Hydrochlorothiazide maybe is 12. So we're careful every time we prescribe chlorthalidone. We start at the lowest dose, 12.5 milligrams. We check a potassium a week later and then another month later. And we tell them most likely you're going to need potassium replacement. Increase your potassium in your diet and so forth. But it works great in people with resistant hypertension and has the best data out of all the diuretics in terms of outcomes in hypertension. It has more trophies than hydrochlorothiazide. The big trials have used chlorthalidone and looking at outcomes. So I'm not surprised that happened, that the potassium was lower in the intensive therapy and the sodium was also lower. So these are the summary and conclusions. Yes, there was a rapid and sustained difference between the systolic in both groups. The trial was stopped early due to benefit after a median of 3.2 years. The incidence of the primary outcome, the composite of all these cardiovascular disease events, was 25% lower in the intensive compared to the standard group, and all-cause mortality was reduced by 27%. Powerful data, correct? So you got to explain this to your patient. Is this a good idea when you're 75? And I have a case that we can go through. The number needed to treat to prevent primary outcome event of death was 61 and 90% respectively. So side effects were not different. Yes, in people without CKD, expect that your GFR is going to drop greater than 30% in some of them. And overall, the benefits of more intensive BP lowering exceeded the potential for harm. That's a valid conclusion. So this is the comparison between the two biggest trials that we have, one in diabetics, one in non-diabetics. Like I said, the average age on the Accord was definitely lower. The BP targets were the same. The Accord in diabetics showed no benefits. The SPRINT trial in non-diabetics with no history of stroke showed benefit if you go down to close to 120 before 140. So a few months after that trial was published, they asked 2 nephrologists, one from the University of Chicago and the other one from the Mayo Clinic, what would you do? And this is really a true statement of what people are doing out there and what we're doing, because it's two different options. So you have a 75-year-old female who would like to discuss the recent trial results. What do you think about lower the BP might be better? Past medical history, hypertension, AFib, peripheral vascular disease with claudication. She fractured her left wrist 6 years ago when she fell. And these are her medications: metoprolol, apixaban, an anticoagulant, chlorthalidone, a good dose, aspirin, and a statin. Her BMI is 26. Her blood pressure is 136/72. That's not bad at all, isn't it? Correct? The first thing that you say, just leave her alone. I mean, correct? The JNC guidelines is right there. You can calculate the Framingham heart cardiovascular risk at 10 years, and it's less than 7%. So her LDL is better than mine. Her cholesterol is 174. Her kidney function is normal, correct? So what recommendations do you make to her about the management of her blood pressure? Should you add an agent or not? So they asked Dr. Backers, they said, you know what? She has history of falls and she's on anticoagulation. The potential harm with increasing BP meds or adding medications is a problem. She may fall again and bleed into her brain if she has head trauma. Her 10-year Framingham risk score is definitely low, 7%. She's already being targeted with lipid therapy and so forth. The JNCA recommends the goal of less than 150 over 90 for persons over 60 years of age, based on the trials that I just showed you, 5 randomized clinical trials. I did not show you the observational studies, but it's the same thing. In the SPRINT trial, the risk of serious adverse events for hypertension and syncope were 67% and 30% higher. That's true. So what do? These guys say, just leave her alone. You're right there. She's doing well. The data suggests that you don't have to do anything. But then the SPRINT trial, and this is Dr. Taylor from the Mayo Clinic, he says that, hey, the SPRINT trial really shows strong evidence to support lower BP targets in persons above 50 who do not have diabetes. She doesn't. Many patients will accept small inconveniences such as having to get up slowly to avoid symptomatic hypertension or taking an extra pill. In my experience, I don't think that's true. When we explain to them, hey, you're going to take 3 meds, I'm going to draw more labs, your electrolytes may be abnormal. This is one trial that has powerful data. The benefit is only 0.5% difference between the events per year. I need to treat about 91 for you to benefit, or that's the number that sometimes we quote. Do you really want this? And I have plenty of randomized clinical trials that show that you're okay are below 150 over 90. Some people, in my experience, say, yes, please add the medication. And some other people say, no, leave me alone. That blood pressure is good for, based on some of the clinical trials, is good enough. I don't think that I want to take the risk of having these other side effects. And I think that the risk that I'm decreasing is too small. I don't want to deal with this. I don't want to come back here too often to get labs and so forth. And they do it. There's some other people that actually, they say, no, Dr. Rueda, please, let's try that. What would you suggest? And so my point is you have to look at the individual and discuss that with time and decide if this is a good idea or not. Since the SPRINT trial was released, we find ourselves adding more meds after we explain that to patients. But we tell them, you gotta come back and you gotta get labs from me, and I wanna make sure that your blood pressure doesn't get too low. So they are spending money on the blood pressure cuff. They're calling us more often. Now we have phone visits scheduled every Monday because we want to make sure that we're not hurting these people. And some of them, I got to tell you, maybe 3 out of 10, they stop the added medication and they just continue where they were taking before. And the rest of them are tolerating the more aggressive approach. And it doesn't have to be below 120. If you look at the mean blood pressure was 121. So if they get to 125, 127, they're fine. At that point, we leave them alone. If they develop any symptomatology, dizziness, lightheadedness, we are scaling down on these people because we don't want them to get into trouble. So that's what SPRINT trial changed in terms of the guidelines. So you have to approach this on an individual basis. This is an investigator from the East Coast of Frank Messerly, and he had this in the annals, and I thought it was hilarious. So So after reading the sprint trial, what are the two options that you have to discuss it with your patients? And one was, yeah, very enthusiastically tell your patients that lowering your blood pressure less than 120 by taking 3 drugs every day for more than 3 years, we're going to reduce this risk by 25, 27%. And the risk adverse, the risk of adverse side effects increases from 2.5 to 4.7%. Or based on the same numbers and the same data, you can tell them what I just explained to you, that, hey, you're going to take more meds. You got to wait at least 3 years to see the effect. The reduction in these events is from 5 out of 100, from 7 out of 100 down to 5. That's really like 0.5% difference. And you have all this risk augmented: hypertension, syncope, electrolyte abnormalities, hyponatremia. Your creatinine may go up as much as 88%. It's the same data, and you have 2 different approaches. All right? So you have to decide for your patient. You know your patient better than anybody else. What would be a good idea for those guys?
Two observations. One, do they take into account waist circumference? Because I know with increased adipose, you have more vasculature.
I don't know. Don't know, but they have BMIs reported. But I don't remember if that was the case.
Okay. And then the other thing is, I would think the pharmaceutical industry would like the sprint report.
Absolutely, everybody's jumping up and down because of that, correct?
So I'm sure doctors are kind of torn between.
Well, we are, and but this is what we want, correct? Randomized clinical trials, and that's what the data showed. And they spent enough time looking at these people. Everybody in the United States collaborated, including, Oregon. So this is the data that we want. So I cannot, having these randomized clinical trials, in a way, is a luxury for us in terms of, with all these patients, 4,000 in each group. So I believe the data, obviously, and I try to accommodate that to the patients that we see in clinic. This is, if you had a stroke, you don't qualify for that. If you're in a nursing home and you're very frail, this is not for you, correct? So you have to really choose which patients are willing to, that you're willing to try this. And if they're, if they don't understand what you're doing and they can't come to your clinic and no one is taking the blood pressure and they're symptomatic out there, I think that you may do a more harm than benefit. If you're there to 135 or 75, leave them alone. But you're not, and they are very active, functional, and they really understand that the risk, even if it's 0.5%, I want to take it, the mortality rate goes down, go ahead and do it. Somebody was going to ask another question. All right, so a few 850. A few words about this issue of secondary hypertension. So, like I said at the beginning, primary aldosteronism is the most common cause of secondary hypertension that we see in our clinics. The rest of them are extremely rare. Cushing's disease. It's very difficult to diagnose. It's painful to do the collections of urine for most people. We now use salivates that we send with the patient, and they can, we measure cortisol in the saliva 2 nights in a row. They soak this little foamy thing, and then we send them to the lab. And we measure cortisol as a screening test for Cushing's. Otherwise, you have to do a low dex suppression test or a 24-hour urine collection for cortisol. We talked about the renal vascular disease and CKD. The most common test that we use to screen people with renal vascular disease is an ultrasound. MRIs, we kind of lost them because the gadolinium toxicity. Most of these patients have creatinines of 1.6 or above. When you give gadolinium, you have this risk of developing nephrogenic systemic fibrosis. Gadolinium is a metal that accumulates in your body if your GFR is low, and there is no cure. They develop these contractures and so forth. The risk is low, but the FDA tells us that if the GFR is below 30, avoid gadolinium. We avoid gadolinium in dialysis patients. If we have to do it, we have to hook them up to the machine within an hour because dialysis removes the gadolinium 80% of the cases. And then we have to do another dialysis around 12 hours later. So we kind of lost the MRA with contrast. The CT, obviously, you use a different contrast, but it's nephrotoxic. So when your creatinine is above 1.6, 1.5, the risk of contrast nephropathy is definitely elevated. So what we have now is, hopefully we have a good tech that can do an ultrasound and look at the renal arteries to see if there is any obstruction. It has to be 80% or higher. Otherwise, it really is not causing your hypertension. So what is primary aldosteronism? That's the definition that is in the Journal of Clinical Endocrinology and Metabolism in 2016, correct? So your aldosterone is mediated by, could be linked to high renin and low renin, correct? If you get dehydrated, your renin goes up and aldosterone goes up. Aldosterone retains water and salt, gets rid of potassium, maintains your volume, correct? So you need aldosterone to get you out of trouble when you're dry, correct? And that aldosterone being high, the genesis of that was the renin being upregulated, correct? Here we're talking about aldosterone production from the adrenal gland that it has nothing to do with renin, just maybe a mass in the adrenal gland or bilateral adrenal hyperplasia or a genetic mutation that increases the activity of aldosterone synthesis that increases your aldosterone, but the renin gets suppressed, okay? That's what we're talking about. So there is primary aldosteronism, that one, and there's secondary aldosteronism. If you have a renal artery lesion, the kidney feels that, hey, I'm not getting enough blood supply. Let's go up on the renin because I want the aldosterone to go up and maintain my blood pressure. That's secondary hyperaldosteronism. This is primary, okay? Sometimes the potassium is down, maybe in 30% of the cases, but most of the time the potassium is completely normal, okay? And what are the causes? A benign tumor of the adrenal gland or a malignant tumor of the adrenal gland, extremely rare, very rare. Or you have bilateral adrenal hyperplasia. Or you have something called glucocorticoid remediable aldosteronism, very rare mutation in one of the genes. Is an autosomal dominant, extremely rare. But if you don't think about it, you're never going to diagnose it. We have like 5 cases of that stuff in our clinic. So this is the clinical features that you might see when somebody presents with hyperaldosteronism. But like I said, you don't have to see the potassium. You don't have to see the metabolic alkalosis. What you see is the aldosterone has to be high and the renin has to be suppressed. How high does it have to be for me to get excited about it? 15 nanograms per deciliter or higher, and the renin has to be less than 1. Plasma renin activity. That's the test that may cost you $300 if you don't know how to do it. Has to be done in the morning, before 10 in the morning. Aldosterone has a circadian rhythm. It goes up in the morning, it goes down in the afternoon. If you were to draw these levels at 3 p.m., you may miss 30% of the tumors or so. So it has to be done in the morning, and you have to have a potassium. Potassium affects aldosterone secretion. The lower it is, drags aldosterone lower. So we have one case, he presented with potassium of 3.1 and the aldosterone was 16. So he said, well, we need to repeat his K and repeat the aldosterone and renin on Monday. So we repeated that. His K went up to about 3.5. His aldosterone went up to 60 and his renin remained suppressed. We had a positive screening test. That kid ended up with a genetic mutation, very rare, but he failed the screening test, and his aldosterone wasn't that high at the beginning. We needed to repeat his K in order to get the right test and look at the numbers the right way, okay? So when you order this, make sure that the potassium is well controlled and do it in the morning before 10 in the morning. Otherwise, you're gonna lose a lot of money and you're never gonna go anywhere. Why hyperaldosteronism causes high blood pressure? Well, aldosterone binds to the receptor here in the principal cell. This is one of the cells in the kidney. This is the sodium potassium ATPase pumps, tells that pump, hey, speed up. And tells the sodium channel to upregulate, to open up more sodium channels and get more sodium into the cell and into your body. So if you have hyperaldosteronism, volume expansion, more salt and water gets absorbed, and then you're going to kick potassium into the urine in about 30% of the cases. That's the reason you see hypokalemia. So having a high aldosterone with suppressed renin is going to cause hypertension. So how do we treat these people? Hey, we have 2 medications that block this receptor, spironolactone and eplerenone. So you diagnose somebody like this, you can actually provide medical therapy that is just targeted to the problem, or if you have an adenoma, I can send you to a surgeon and remove that adrenal gland. And that can cure you of the hypertension in about 30% of the cases, or improve your blood pressure control in about 80% of them because you need less meds. So another point that I have to make, 20% of the people that you see in your clinic with resistant hypertension might have a positive screening test for hyperaldosteronism. So if your blood pressure is 150 over 100 and you're taking 3 meds, including a diuretic, and you know that the guy is taking the medications, you have an indication for screening this guy the right way. Get a potassium, figure out where you are, and then do the screening the next day in the morning. Yes?
2 things. What was spironolactone and what was the other one?
Eplerenone.
Eplerenone?
Eplerenone is Eplerone.
Okay.
Is it? Yes.
And then at that point, should we be referring them to a nephrologist, or should the GPs be doing it? Or
Well, I want them all. So yeah, send them in our. Yes, the answer is yes, because there's a few other things that we do. For example, looking to see if there is an adenoma that we can correct surgically. And there is, like I said, there is a genetic mutation that there's maybe 400 cases in the registry out of Boston with that mutation. And like I said, we have 5 cases and now it's commercially available. We do that test before everybody goes to the OR. They're going to get an adrenalectomy. So that said, less than 1% of the people with primary aldosteronism have a genetic mutation. And just maybe 5% have adenomas. Most of them have bilateral hyperplasia. And you can treat those with those meds, okay? And there is maybe another MR receptor blocker coming into the market. I think it's Finerenone, the name. So maybe in the next year or so, we'll have another medication that we can offer them. So these are the guidelines. If you have some time, look them up. Actually, they're very good. The guys that really know about these out of the Mayo Clinic and Australia put this together. These are the indications for screening. And I'm going to be honest with you, we don't do this because it's too much money. We have too many people with systolic is 150. Remember that you spend a lot of dough screening for these patients. We do this. Uncontrolled resistant hypertension. If you're taking 4 meds, you definitely benefit from that. If you have an adrenal incidentaloma, we see a lot of those patients in our clinic. They come here, have a toothache, get a CT of the abdomen, and then bingo, they have a 2-centimeter mass that looks benign on the adrenal gland. So what test do you do in order to work this patient up? One is aldosterone and plasminogen activity. You got to rule out pheochromocytoma, you got to rule out Cushing's, correct? So we see those patients and we go through the screen and see if they have a problem. Very young patients with hypertension should be screened for that. This is debatable, hypertension and sleep apnea. And if you have a family history, somebody had very early onset of hypertension, or somebody ended up bleeding in having a bleeding or stroke at an early age, this could be hyperaldosteronism related to a genetic mutation. They have higher risk of bleeding than people with polycystic kidney disease. And this is data based out of the registry that they have of 400, 500 patients. So this is what you want to look for, but it's not that big. In our data, it's about 1.5, 1.6 centimeters. And it's a fatty tumor. This doesn't become malignant, but it can cause severe hypertension. All right, we're almost done. Wake up. So 20% of those patients with resistant hypertension may have these positive screening tests. You know how to do it now. But look at, this is based on the JNC staging for high blood pressure. 13% of the people that have systolics in the 180 may have this problem. And this is the data that the Endocrine Society might have used in order to add that screening indication in their guidelines. Because the people that have these 180, some of them, you're missing the diagnosis and they have maybe primary aldosteronism. So once you do this screening, then you got to think about, do we do imaging? Is he a good candidate for adrenal vein sampling, is it a good candidate for surgery or not? And some of the most common questions that they ask us is, okay, Dr. Rueda, what do we stop before we check for the aldosterone and renin? Because a lot of the medications out there really affect aldosterone and renin. For example, ACE inhibitors, they decrease your aldosterone, correct? That's how people become hyperkalemic. They develop hypoaldosteronism. What about losartan, ARBs? They do drop your aldosterone levels as well. You develop hypoaldosteronism with these two meds, and they can cause hyperkalemia, and it can really affect your screening, correct? What about direct renin inhibitors like aldosteronism? Very potent medication that inhibits your renin, and you stop the medication now, and the renin is still inhibited for 2 weeks later. So those medications, this one, amiloride, spironolactone, or eplerenone, have to be stopped at least 4 weeks, the guidelines schedule 6, before you do a screening in the morning. We don't stop the other ones. We keep the calcium channel blockers, the beta blockers, the ACE inhibitors, and the ARBs, because otherwise the risk of stroking these patients out is too high, correct? You have to balance things out. But the ones that you have to stop are these ones. Amiloride blocks the epithelial sodium channel in the kidney, affects your aldosterone and renin. Motrin decreases your renin. You don't want to do the testing when somebody's taking Motrin BID, correct? And then 4 weeks later, you do the testing on the other ones in the morning at 10 in the morning. We do plasma renin activity. You can do renin levels. Our hospital doesn't do that. We favor the plasma renin activity, which is an in vitro assay. They measure how much angiotensin 1 you form, and that's what we use to look at the ratio. And the aldosterone in nanograms per deciliter. And these are the three options. You're here. There's nothing else besides primary hyperaldosteronism when you find a low renin and high aldosterone. You may end up having some other causes of low renin and low aldosterone, very rare. Little syndrome, Cushing's, Geller syndrome, extremely rare, or a parallel mineralocortical excess. And when you have both of them high, could be that you just dry, or you have a renal artery lesion, or you have a vasculitis or malignant hypertension. One of my colleagues has this graphic printed out next to his computer, because he does a lot of the renin profiling in people with severe hypertension. And I always tell him, there is nothing else here, man. So if you have a low renin and high aldosterone, keep up with the workup, because you may find something. This is it teaches you what to do. For example, a week ago we had a young guy, 35 years old, with severe hypertension, and they did a CAT scan, and he had a 1.5 centimeter mass on the left adrenal gland, 35 years old. His potassium was very low, 3.1. His blood pressure was very high. His renin was suppressed, and his aldosterone was about 30. So what do we do with this kid? Do we go and tell him, just go to the OR and remove that adrenal gland now? And the answer is, yes, you could. Because the chance that you're going to have something on the other adrenal gland is very minimal. But if you were to be 40, you will need an adrenal vein sampling. The surgeon most likely is not going to take him to the OR until we show them that really the aldosterone secretion is coming from that tumor, okay? So these decoys could be present. The older you are, the higher the prevalence of having just an incidentaloma that is not doing anything. Up to 7% of people above 60, 70 years of age can have a decoy that is not producing anything. And then you don't want to remove the wrong adrenal gland, correct? Bilateral adrenalectomy is not an option. It's a worse disease than what they have. So for this kid, 35 years old, he met all these criteria. The CT showed a benign tumor in one of the adrenal glands. He said, you go to the OR. You have primary aldosteronism. The only thing that we have to do is, let's do this genetic testing. There's some people with this syndrome that may have a tiny little mass. If that's negative, go for an adrenalectomy, and most likely we're going to cure you from your blood pressure. He takes only 2 meds. He has definitely a very low potassium, but his blood pressure was in the 160s. But if you're older, you're going to need an adrenal vein sampling. And then we don't do too many of this, but we've done about 135 in the last maybe 15 years. And we have only one radiologist dedicated to this. It's tricky, and I'll show you why it's tricky. And out of all these adrenal vein sampling, we've done only 35 adrenalectomies. So we really choose the patient that needs to have this done because it's very expensive, okay? And that if they're not candidate for surgeries or they don't want surgery, they want to take medication, we won't go through this, okay? There's nothing wrong with treating them with spironolactone or pleuronone. The outcomes of 5 years are very, very good, okay? So this is what they claim over here. If you have bilateral disease, you give them the MR antagonist. If they have definitely the tumor, you have deemed them good candidates for surgery, they go for an adrenalectomy. And it is laparoscopically. They may go home the next day or the same day. It's amazing. So CT matters. Because the radiologists tell us, hey, this guy has an adrenal mass, but the Hanfling units are on the low side, so it looks like a fatty tumor, correct? So that's what we want to hear. If the Hanfling units, which is a marker of density, they're higher, this is a benign tumor, this is a pheochromocytoma, the Hanfling units are 40. See the density is different? So this looks bad, and you can present with hypertension, and you have a tumor in the adrenal gland. He needs to go to the OR, you need to alpha blockade that patient, and do the biochemical testing, correct? But even if the biochemical testing is negative, imaging phenotype trumps it. If it looks like a pheo, it is a pheo, and you go to the OR and get that out, because that can kill you or become malignant. This is a benign mass. This is something that, you know, if we've seen once, that's about it. Adrenal carcinoma, big masses. So this is one of the reasons why the CT is definitely helpful. And the radiologist sometimes can see the anatomy and go from there. Why is so difficult to do the adrenal vein sampling? So they put catheters in the adrenal glands, and we measure cortisol and aldosterone sequentially to really truly find out which adrenal is the one that's causing the problem. So this catheter goes here, right here. This is the inferior phrenic vein. So the adrenal vein, and we get the radiologist gets the sampling here. So as you can see, it's diluted. And this is the other one. This little vein here, the right side, is maybe 7 millimeters in length and 3.5 millimeters in diameter. So it's very difficult to get to that right adrenal vein, but our radiologist will look at his data. 90% of the cases, he gets it right. How do I know he gets it right? Because we measure cortisol in every single sampling here, and the cortisol here has to be 5 times higher than the cortisol in the periphery. When he sends the results and it's now 5 times higher, we send back the email, that needs to be repeated. Otherwise, I'm not gonna tell the surgeon, yes, go ahead and remove that gland. I gotta make sure that you were in the right adrenal vein. So, and this is the report. I mean, you don't have to be a nephrologist or radiologist to figure out there's something going on in the right adrenal, correct? So the ratio's very high between the two, and then you tell them that you were in the adrenal vein. We believe that the sensitivity of this is very high, and we have proven that the chance that we remove that adrenal gland and it's normal in pathology is very small. So we tell the patient, okay, you got a problem in the right side. Let's send you to the surgeon and see if you can get cured. And I think that's about it. I think I run 10 minutes later. Any questions for me? We have the case. Should we go with the case, Paul?
Sounds good.
Okay.
For patients that you encourage to test their blood pressure at home, how reliable are the home testing machines?
So the things that we do, we bring their, they bring their blood pressure machine to our clinic, and we compare that with the NRA that we have. Then we looked it up in that database that you guys saw the first slide to see that has been validated by that company. And then we do 2 or 3 of those in the clinic. And sometimes we watch them checking the blood pressure. Believe it or not, most of the time, they don't know how to do it correctly. And then if they pass the test, we tell them you're gonna do 2 in the morning, 2 at night. You get 2 readings in the morning and you do the average. You get 2 readings at night, you do the average. And 7 days later, you send me those readings. And I'll know that you learn how to check it, I know that your machine is okay. And we look at the blood pressure cuff to make sure that it's the right size. And one of our pharmacists gets these blood pressure machines for free. So as soon as we have a patient, we call him and he goes and measures the arm and so forth, and we get the right machine and so forth. So that's what we do. Do we believe that data? In most of the patients, we do. When we don't, we bring them over here. But 80% of the readings in the clinic are higher than at home. And that is the problem, especially when the doctor measures that blood pressure. The thing is that we have to watch how they do it and make sure that it's the right thing that they're doing and so forth. We don't believe in the finger blood pressure machines, and we don't believe in the wrist blood pressure machines. We found out that they're very inaccurate.
So several of patients have, at least 3 or 4 agents and then a diuretic. They tend to go into hypertension emergency.
Yeah.
So, and then they go into the emergency Labetalol or whatever to bring it down, but kind of recurs. What should they be doing about that?
Well, that's an indication for you to do for the workup. And those patients need to make sure that you have ruled out renovascular hypertension, that you have ruled out secondary causes. So if you go through all these identifiable causes, you have to do a screening for this guy. That patient would benefit from aldosterone renin screening and so forth, and figure out compliance. The most common cause of that is non-compliance with the meds. I wish we had these assay that they use in Europe that measures 154 metabolites, and it can tell you exactly if you have taken your meds or not. Here, we can do blood tests to look at medication levels, but they're very expensive. They charge like $300 to see if you have hydralazine on board. I think you can measure any level except ACEs and ARBs, but it's a waste of money. Sometimes we tell them, I'm going to do a test to see if you're taking this medication. No, I just didn't take it 2 days ago. So I think that the most common cause of that is non-compliance. But if you know that you're taking the meds and they're still abnormal, do the screening for all these. TSH, if they're obese, rule out Cushing's. Make sure that they don't have kidney disease. Make sure that they don't have coarctation. Make sure that they don't have a renal lateralization. Make sure that they don't have a sleep apnea. Make sure that they don't have hyperaldosteronism, and go from there. And then start looking at the meds. The 2 tricks that we use the most commonly in our clinic is we switch hydrochlorothiazide or thiazide diuretics to long-acting chlorthalidone, especially if you have resistant hypertension. And we use a lot of spironolactone, lots of it. It's an awesome med. They respond, and we have clinical data to back it up. The ASCA trial done a few years ago was the 4th best addition to that group to control blood pressure. Spiro works, you start low doses. When you go up to 50 milligrams per day, some men, 10% of them may have some breast tenderness, then we switch them over to eplerenone. The problem with eplerenone is that the half-life of eplerenone is 4 hours only. The half-life of spironolactone, the metabolite, is almost 40 hours. The mother compound is only 4, but it lasts very long. Eplerenone, you have to do a BID, and it's more expensive, and it's maybe has a third the potency. So we really start with Spiro and chlorthalidone on those patients if they go.
It makes sense, because if you don't do all that extra testing, the spironolactone is going to bring down the levels anyways.
Correct. It works irrespective of the aldosterone levels. That's the beauty of Spiro, and it's very, very cheap. So let's go through the case really quick. 59-year-old male. He came from Hood River, actually. 10-year history of hypertension on 4 meds. He had a stroke already. He was 59. And these were his labs. The potassium was 3.1. His blood pressure definitely was elevated. He was on atenolol, lisinopril, hydrochlorothiazide, triamterene, nifedipine, and a very large dose of potassium. So this guy has, you might say, he has provoked hypokalemia. He's on a diuretic, but he's losing a lot of potassium. But it's very odd that he needs 120 milliequivalents of potassium to maintain a KO3.1. So when you have a spontaneous hypokalemia, definitely, oh man, he has something. But when you have provoked hypokalemia, you say, how much potassium is he getting? That's a lot. So that's a problem. He has hypokalemia, and that was the red flag. This guy has something, correct? That potassium is too low, he's taking too many meds, he's very compliant, and he already stroked out. So we gotta figure out what is going on. He had family history of hypertension. So we did the aldosterone and the renin. We told him, come in the morning, and we're going to give you potassium. His potassium went up to 3.5. His aldosterone was 33. His plasma renin activity was 0.1. So anything below 1 is suppressed of the PRA. Anything above 15 we get excited about. The ratio was enormous. So he had a positive screening test for hyperaldosteronism, correct? So what do we do next? Sometimes we do a confirmatory test. We give them salt and we measure the aldosterone in the urine. If it is greater than 12 and the sodium intake is 200 milliequivalents and he has greater than 12 micrograms of aldosterone, why he has so much aldosterone if he has plenty of salt? He has to suppress his aldosterone. So maybe something is producing that aldosterone, correct? But I didn't want to do that because he just struck out before. If I give you salt for 3 days and do a collection of urine, he may end up in the ER with another stroke. So I kind of sort of sick with that, and let's go through imaging. The CT was completely normal. There was not an adrenal mass. So what do we do next? So we talked about, maybe surgery would be a good idea, but we got to figure out which adrenal is causing the problem. And we went and did the adrenal vein sampling, and the lateralization of this aldosterone production, the ratio was 4:1 from the left side to the right one. So I said, we can offer you a left adrenalectomy. I'm going to tell you that I'm going to cure you from the hypokalemia, 100% of the cases. He said, yes, I don't want to take this potassium anymore. We may improve your blood pressure as well. And it's tricky. We tell them 30% cure rate, but 80 or 90% of them get better, and they don't want to take all these meds. And we told him, look, hyperaldo patients have a high risk of MIs, high risk of atrial fibrillation, high risk of microalbuminuria, so you might benefit from this. Plus your blood pressure is going to be better controlled. He said, yes, let's do it. We removed the adrenal gland. This is about 7 years or 8 years ago. And he completely cured. He doesn't even want to come back for follow-up. He said, no, I don't take anything anymore, and my potassium is fine. Why you need to see me, doctor? So he said, okay, go back to your PCP. So we've seen cases like this in which sometimes the screening tool is just the electrolytes and the aldo and the renin that makes you go, or the fact that he had the stroke and he's on 4 meds and the potassium is low. That's when you have to think, okay, this is a problem. Those are the patients that we want to see, because sometimes we find something that they would benefit, targeted therapy, the right medications, or a surgical approach. And that's about it. I mean, I don't have any other points to make today. Go ahead.
So when a patient calls in to our clinic, they're having blood pressure issues, they find out they have a cardiologist and a nephrologist. Who do we direct them to?
Well, let's put it this way. If they don't have any chest pain, they belong to us. So we know how to do this. This is what we do for a living. We get plenty of referrals from the cardiology department. But when they go into, does he have a renal vascular lesion, any aldosterone producing tumors, does he have any genetics that we need to look into, what other meds do you suggest that we do, they usually calling us for help. So, and that's the reason we have a hypertension clinic at OHSU. If there is somebody very complicated, we have 10 different providers that we can consult on. That's all they do. They see patients with uncontrolled hypertension. Plus, most of our researchers, they spend time doing this.
Because on observation, the providers, in my experience, they tend to refer to cardiology for uncontrolled hypertension.
I know, nobody's perfect. But you can always, there is a consult line at OHSU. Utilize that. And we can maybe bypass 1 or 2 visits and then do all this workup before we see them and then go from there. And it's free. You call the consult, you want to talk to the nephrologist, and sometimes, we can get them in the hypertension clinic as soon as we can.
And is that just OHSU, or do all nephrologists do
So
this?
you can call any of the nephrologists at OHSU and they can direct you to the hypertension clinic on the consult line, because there's plenty of nephrologists that rotate through that clinic and help us. I staff most of the clinics, but there is plenty of other providers that go there. So yes, utilize that. That's the reason it's free. and we can help you. And we can always tell you what to do, how to do this screening, or change the medications around, and do these and do that, and then we can see in our own clinics.
Do you know if there's any restriction with insurance, family care, CareOregon?
No restrictions. We see people with no insurance often. Any other questions?
You mentioned at the beginning that monotherapy is a thing in the past.
Yeah.
What's the rationale behind that?
Well, if you look at what is the best scenario in the clinical world? Is a randomized clinical trial, correct? So if you look at, so that's when you pay attention to these patients the most, correct? You go through the meds, there's a dietitian, you change all of these things. Even in a randomized clinical trial, multiple times, the answer is you need 2 meds, okay? And maybe it's because if you look at all the trials in hypertension they've done in the past, a medication, and one medication only, may give you 9, 10 points. That's about it. And some of these other people need to get down 20 points or higher, when their systolic is 170. So there is no, and some of these meds work synergistically, ACEs and diuretics and so forth. So that's the reason one med is not gonna really do the trick in most of the patients that you see out there. You're lucky if 10 milligrams of lisinopril is gonna do the trick. And what's a good dose? That's another question. Why you guys stop at 10 milligrams of lisinopril? What is the recommended adequate dose of a blood pressure pill to treat hypertension? If you don't know, you go to the PDR, open that up. Look at the maximum allowed dose of lisinopril. 50% of that or higher, that's the recommended dose for blood pressure control. So it's not 10 milligrams a day. So look it up and figure out 50% or higher the dose, and that's the dose that I have to use. What else I can tell you? Beta blockers. We don't like, for example, atenolol in our clinic. The FDA now doesn't allow you to have a group with atenolol because they always lose. Right? It's cheap, but doesn't have the best record in terms of outcomes. Right? So we don't use atenolol. Cardiologists definitely use a lot of metoprolol. We love carvedilol. They have done a trial comparing carvedilol and metoprolol in patients with diabetes, the Gemini trial. And carvedilol really kill it. They have less insulin resistance, better blood pressure control. The only problem had to be used BID, but it's a $4 med, correct? And in our experience, dialysis patients, CKD patients tolerate that very well. So we have our own favorite sons, spironolactone, chlorthalidone, carvedilol, those 3. And in terms of the ARBs, you can't really choose much because the only generic that we have is losartan, but it's the weakest, has the shortest half-life, but that's the only one that we can use, but we use it BID, okay? The rest of them are really equally potent, but the least potent, efficacious, is the one that we can afford, losartan, but we give it BID. Any other questions?
I think what we should do, guys, is just in light of the time, let's save some questions for the end. If we have a couple extra minutes, we got to keep the train on schedule. Let's take a quick break. Before we do, please give a huge round of applause to Dr. Rueda.